I'm going to be the first speaker, and then I'm going to pass it off to my partners in crime, Drs. Ko and Hung. And again, we're really delighted to share what we've been working on, especially with this group, really, because we're pretty excited about it. And we really welcome feedback and just questions and just new directions for us, because we feel like we're really busy and there's sort of a lot that we're taking on. So again, our project is about promoting healthy aging among World Trade Center responders. And we're specifically focusing on frailty trajectories and intervention strategies. Again, we have two different grants that our work will speak about, and we don't have conflicts to report. So just an agenda to help me think straight. Mostly, we're really going to focus on what work we're doing within the World Trade Center Health Program, and specifically try to explain why we're studying frailty, why now, what we're doing, and we'll give you some background on frailty, since I know this isn't a geriatric audience, a geriatric research audience specifically. And then we'll talk about the World Trade Center Clinical Frailty Index, which is a measure we've developed previously, and how we're using it in this current study, where we're focusing on frailty trajectories. We'll tell you a little bit about our study recruitment process, and always will be welcoming feedback on that. And what we're really excited about is some of the planned intervention activities that we're using our data to develop. So again, the real goal of our project is to understand how previous World Trade Center exposure may lead to premature age-related deterioration in physical function. And the idea in doing this as to why is because we truly want to improve the ability to care for responders as they age, to really try to understand what the unique needs are, and to make it so that our health program actually supports them in this way. So again, this is, I keep moving our faces away from the data for myself, but okay, there we go. But again, we all know that there's existing epidemiologic surveillance. And with that, we recognize there's been incredible work with all of the health data that's collected during all of the monitoring visits. We see specific illnesses, notably GI, respiratory illnesses, cancers, that we can identify early and understand early signs of these disease and their association with World Trade Center related, what are now World Trade Center related certified health conditions. In the context of this, coming from a background in geriatrics, we're really concerned about the age of the responder cohort. It's hard to believe it, since 20 years have passed, but by 2030, the majority of responders will be 65 and over. And that's really a big deal. And because of that, they're at risk for age-related conditions. And it really becomes a concern, less about some of these specific health conditions, but we start to really think about multimorbidity and many kinds of illnesses that may occur in this population. And currently, again, so sort of the research so far has been very much on individual illnesses for good reason, with incredible findings and, really important. But as the current cohort is 59, I think it might be 60 by now, there's really an urgent need to think about routine assessment of what we do in this population this age normally, is really thinking about frailty and other age-related indicators, physical, cognitive function, things like falls. So with that, I want to introduce the concept of frailty and sort of what it is that we're talking about in doing this. And essentially, frailty is thought of as a clinical syndrome characterized by multi-system physiologic decline with increased vulnerability to stressors and adverse clinical outcomes. It's associated with decreased muscle mass and strength, decreased physical activity, weight loss. And you can see here on the right, all these signs that we see it's associated with. And consequently, we have higher mortality, We have surgical complications, various negative outcomes related to increased frailty in the population. So in geriatrics, this is something we measure routinely. It's a major concern for different outcomes in the population. So how do we measure? We often measure it in what's considered a phenotypic approach, where we actually look at 5 different assessments: unintentional weight loss, weakness, which we measure with a grip strength, essentially, exhaustion, and we actually measure walking speed for individuals, as well as low physical activity. There's a very well-known assessment calculator here at Hopkins that we use that's pretty standard to measure frailty. Another way we do it, and which is often done in the context of clinical assessments or in EMR-based studies, is what's considered an accumulation model or a clinical frailty index. And in doing this, frailty is essentially measured by computing multiple deficits across multiple domains. So you can see here in this figure, we might look at cumulative medical conditions, different measures of disability, cognitive decline as part of it, as well as poor nutrition. So we often think of these 2 different approaches to capturing frailty. So what we've done so far in work with the World Trade Center responder cohort is we've developed a 30-item clinical frailty index specific to the World Trade Center responders, basically using the second model that I showed of sort of a cumulative deficit model. And what's great about this is we're using health monitoring data that we're routinely collecting from medical and mental health questionnaires and the physical exam to do this. So just to give you an example, we take measures such as, did you ever have pneumonia or diabetes? Do you have persistent fatigue, unexplained weight loss? These are questions we already capture in our population. So we use this and can put this together, and we've a validated index that's associated with age as well as increased mortality. And interestingly, the work that we found in doing this is that this index, so this measure of frailty, as in other populations, routinely we see it associated with increased age, as well as women being more likely to be frail. But we also see some aspects of it that are important for this population, requiring further study. Specifically, we see pre-9/11 occupation. We see an increased risk of frailty among those who are construction workers, and these are in models where we're simultaneously adjusting for multiple factors, as well as a very high exposure, World Trade Center exposure severity. So this is really an important issue, really thinking about how exposure itself may be associated with the frailty process. So in doing that, it brings us to our current grant, where we're actually trying to understand frailty trajectories and risk factors associated with trajectories using longitudinal monitoring data from the World Trade Center responders, and to continue to validate our clinical frailty index, because we want people to routinely measure frailty in this population. And more importantly, we'll talk about this again, we're starting to pilot an intervention targeting frailty in the World Trade Center population. So with that, I want to transition to my colleague, Dr. Ko, who's going to speak about the
Great.
first aim.
Thank you so much, Katherine. As Katherine had mentioned, the first aim of our study focuses on frailty trajectories. And there are multiple reasons why frailty trajectory is the focus for this aim. Some of those are listed here. So for instance, point estimates of frailty, while it's predictive of certain outcomes, it does not adequately capture the variability in the progression of frailty with age. In many different aging cohorts, different frailty trajectories have also been noted, in that the frailty trajectory that's the steepest, meaning that it's the most rapidly rising, is thought to be associated with higher mortality. There's also data to show that longitudinal data, such as the ones in the WTC general respondent cohort, could be used as a means to study frailty trajectories, as well as the factors that are associated with frailty progression. So the analytical plan for this aim focuses on using WTC clinical frailty index that Katherine had talked about, using the frailty index score that's collected over a period of time in order to assess changes in frailty with time, with age. Using statistical modeling. And the goal of this is so that we can identify risk factors that are associated with these distinct frailty trajectories. Risk factors that are not modifiable, such as sex, race, and pre-9/11 occupation, as well as those that are modifiable, including obesity, nutrition, and polypharmacy. So in the next few slides, I will show you some of the results that we have so far. We have used the latent cluster mix model to analyze the data. We look at data collected over a period of time from 2004 to 2020, including almost 18,000 subjects over 80 distinct clinic visits. So using these analyses, we identify 3 distinct trajectories as shown here on the left. On the bottom is the red group, or the red line that we call the low frailty index group. In this group, the frailty index score was low across all ages, and it increased gradually over time. We subsequently used this group as a reference group for the regression models that we'll talk about in a moment. The green group, what we also call the sustained increased frailty index group, had low frailty index score at younger ages that increased rapidly over time. And lastly, we have the blue group, which is what we call the high frailty index group. And this group has the highest frailty index score across all ages that increase moderately over time. We then use multinomial regression models to examine the associations between frailty trajectory membership that was treated as a categorical variable and its association with WTC exposure severity, as well as some socioeconomic characteristics. And these are the findings. We found that frailty trajectories are associated with WTC exposure severity, as shown in the graph here, and that the higher level of WTC exposure severity was associated with a higher risk of frailty trajectory. Again, the red group, or the low frailty index group, was used as a reference group. Frailty trajectories were also associated with sex, education, and outcome. Specifically, the risk is increased in women compared to men, as shown on the top left. And this risk was decreased in those who have a education greater than high school, or higher education, or a higher income greater than $30,000. Frailty trajectory were also associated with race and ethnicity, as well as pre-9/11 occupation. As you can see on the left, the risk was increased among Hispanics compared to Caucasians, and it was also increasing those who were in construction, cleaning and maintenance, installation, repair services, compared to those in protective occupations such as law enforcement. So in summary, from our analyses thus far, we have identified latent subpopulations of frailty trajectories that may differ in their rates of progression in this specific cohort. It appears that the WTC Clinical Frailty Index is a robust marker of aging that captures the multidimensional and dynamic nature of frailty over time and is suitable as a measure to investigate frailty trajectories. We're currently doing analyses to further investigate the effects of certain lifestyle factors such as obesity on the progression of frailty over time in order to identify modifiable risk factors that we can potentially target as a part of our intervention. So there are two components to AIM-2. The first is to validate the WTC Clinical Frailty Index using the frailty phenotype that Katherine had described earlier. This is the one where 5 clinical signs and symptoms are used to define frailty. The second component of this AIM is to determine the predictive validity of the WTC Clinical Frailty Index against clinically relevant outcomes. And the overall goal of AIM-2 is so that we can improve the risk stratification accuracy of this index. In terms of our analytical plan, we will refine the previously established cutoff of this index using the frailty phenotype as described. We will also determine the predictive value of the index against specific geriatric outcomes such as functional and cognitive decline. And the first step to doing so is to establish a longitudinal cohort of 400 members of the general respondent cohort, general responders from the Mount Sinai CCE. So I want to show you some of our pilot data. We have developed and tested the protocols that are required to assess frailty, cognitive physical function in the general responders. The baseline characteristic of this cohort of 106 are shown on the right. And as you can see, frailty was associated with BMI, WTC related certification, as well as WTC certified mental health conditions as shown on the bottom right. Frailty was also associated with activities of daily living, fall risk, and fear of falling. So this is where we are with our enrollment. We are currently enrolling general responders who are 50 years of age or older, who seek care or monitoring visits at the Mount Sinai CCE. Our target enrollment is 400 participants. We have currently enrolled 51 participants as of a few weeks ago. Our recruitment methods, there are several recruitment methods that we're utilizing, primarily a clinic-based recruitment approach. We're now phasing in recruitment by email and telephone as well. We will conduct annual assessments preferably when the patients are making their routine monitoring visits in the health clinic, at the health program. And we may potentially do up to 4 of these visits during the study period. And the measures that we will be assessing are described here on the bottom. And these include different measures to assess frailty, physical function, as well as cognitive function. And with that, I'll pass this on to Dr. Hong.
Thank you very much. So I am going to talk about AIM-3, which is to adapt and implement pilot multi-component intervention on modifiable factors associated with frailty. So the 2 approaches that we have actually considered and will be actually implementing are related to medications. So first is actually polypharmacy, using a pharmacist-led deprescribing approach to actually improve the use of medications among our multi-center responders. And then the second one is actually one that relates to healthy aging. So it's a program, evidence-based practice called Healthy Steps for Older Adults. It is a health promotion and falls prevention program that targets multiple factors. As we actually do see with frailty, that actually does, and for geriatric population, there are multiple factors involved in actually geriatric syndromes and actually poor outcomes as well. So I'm going to talk a little bit about both those. We'll examine the intervention feasibility and acceptability, And particularly important for that is that we are doing this with the World Trade Center cohort, and there is actually a specific setup for the World Trade Center clinical program, and also in terms of specific, maybe actually uniqueness in the actually World Trade Center cohort as well, that we want to actually see whether those actually interventions would be workable in that setting and also in that population. And we want to explore also the impact on geriatric outcomes as well. So this is actually a information that we have actually analyzed on our pilot during our pilot pilot project phase. We actually looked at polypharmacy and use of multiple medications in World Trade Center general responders. And this is actually medication use is ascertained by structured medical history questionnaire and administered by a trained medical professional. And it's asking the question, are you currently taking any prescription, non-prescription, or herbal medications? And a yes actually would prompt the interviewer to list the medications. We would actually summarize actually that by medication counts and also categorizing them into certain types of medications that would be potentially harmful for older adults. The reason why we actually look at polypharmacy and multiple medications is that there is actually a very robust literature that this is actually a really strong factor in associations with poor outcomes for older adults. So, for example, falls, hospitalizations, mortality. Having those large number of medications actually do confer additional risk for older adults. And for an aging population that actually would be accumulating medications with their chronic conditions, particularly some of them are World Trade Center conditions over time, we do want to actually really ascertain what medication use would be most appropriate and in a way to actually reduce the potential adverse effects that would be coming from multiple medications. So some of the data that we have looked at. The mean number of medications is around 6. More than 55% actually already take 5 or more medications. About a fifth of them actually take 10 or more medications. FRID actually is false risk and increasing drug. So those are medications that actually would be conferring risk for older adults in increasing fall risk. So those are medications like benzodiazepines, first generation antihistamines, certain medications that actually have strong anticholinergic effects. Those are actually in geriatrics literature, there has actually been a lot of attention to thinking about how to reduce the burden of these medications so that we can reduce adverse outcomes for older adults. So some of the characteristics that are related to having high number of medications, well, age is one of them. So as we actually think about chronic conditions, accumulation of chronic conditions, and when you think about, for example, high blood pressure takes maybe 2 medications, and for example, heart failure takes 3 medications, conditions, World Trade Center conditions, for example, reflux disease, that's a medication, and other conditions may actually, particularly psychiatric conditions, also actually increase the number of the medication burden as well. We did find that also the number of medications actually is related to the World Trade Center conditions and also in terms of the frailty index as well. So frailty is actually quite a strong factor in predicting the or association with using high number of medications. And we do see some of the World Trade Center conditions that are listed here that also confers increase associated with increased use of medications. So this is honing in on specific medications that may actually be for potentially avoidable or maybe actually potentially risky for older adults. There is actually the use of the medications is not actually associated with age. Maybe actually is because of the conditions that it's associated with, for example, anxiety disorder, depression, or post-traumatic disorder. Those are conditions that are very strong, have strong relationship with false risk increasing medications. Similarly, in terms of frailty index, is also associated with increased use of false risk increasing medications as well. So switching on to the with the preliminary data that we have about the medication use in this in the World Trade Center General Responder Cohort, we have actually considered what some of the approaches for thinking about how to improve the use of medications would be. And this is an evidence-based practice that de-prescribed that is actually a evidence-based approach to identify medications that could be harmful to older adults and reduce its use. So this is actually has evidence in a randomized trial in Canada, and that is actually done in the community where they have medication review by a pharmacist, community pharmacist that actually, and also which actually is followed by having education material that was be sent to patients and then sent by recommendations by the team. And then the prescriber would consider whether to change the medication with the older adult that actually receives that particular education material and recommendations. And the goal is actually to reduce the exposure to potentially harmful medications. So medications like benzodiazepines, medications such as muscle relaxant that may actually not have as much benefit as everyone would hope. The important the important part for our project here is that we really need to actually adapt this to the unique clinic setting. And we really think about the World Trade Center clinical program, not really assuming the primary care of patients, but really for that the World Trade Center clinical program would be actually be providing monitoring and also in terms of treatment of World Trade Center related conditions rather than primary care. So some coordination actually may need to happen related to prescribing of certain medications as well. So there's workflow that is actually clinic setting that actually needs adaptation for this intervention. I'm going to actually also switch gear a little bit to the other intervention that we will be piloting in AIM3, which is to for a program that would be called Healthy Steps for Older Adults. And this is an evidence-based program as well on fall prevention and healthy living. And that was developed by the Pennsylvania Department of Aging and has been endorsed by the ACL as evidence-based. And the goal actually is to think about what some of the poor outcomes that older adults who are actually in a really frail trajectory would be actually coming towards. Increased risk of falls and hospitalizations. And so this is actually a program that would actually have targeting multiple aspects that would actually pertain to frailty as well. That actually would look at how we can actually reduce the risk of poor outcomes for potential frail individuals. So that would actually pertain to environmental safety, thinking about in terms of exercises that would be appropriate for the older adult that is aging, nutrition support, attention to foot health for being a potential cause for fall. And also maintaining an active lifestyle, social connectedness and well-being as well. So this is a prescribed, well-prescribed program that actually has a workshop of that would actually consist of a risk assessment, also followed by a group workshop that is either in person or virtual. So we would actually love to see how it can be adapted to the World Trade Center General Responder Cohort and actually confer some potential benefits for both of these approaches to the health of the aging World Trade Center cohort. So I want to acknowledge both our funder in terms of CDC and all of the World Trade Center responders, and also the Mount Sinai World Trade Center health program. And we have actually a number of investigators that actually look at the different aspects of the AIMS and analysts as well. And we have assembled this advisory board, and some of you may be in the audience that would actually help with our reflect on how we can actually make sure that the materials that we develop would be actually really would be helpful for the World Trade Center clinical program where we actually conduct our study as well. And our program managers and research coordinators as well. So thank you very much. And we'll turn it over back to everyone for questions and comments.
Thank you so much, Drs. Ornstein, Ko, and Hung, for this amazing presentation and for all the information.